When we experience pain, we tend to link it to an injury somewhere in our body. This is usually true. When our body is damaged, might be our muscles, our tendons, our ligaments, our skin, our joints. When those areas are damaged, these cells in that area which are damaged release chemicals. Those chemicals themselves, along with other chemicals released by our immune system, start to stimulate the nerves. The nerves then get activated, they send a signal to our brain, and we experience pain. However, this isn't always the case. In some conditions, termed pain amplification syndromes, it is actually not the case that the amount of pain we feel is linked to the amount of damage in our tissues. Conditions which are in this group, the pain amplification syndromes, include fibromyalgia, where we have widespread pain across the body. They include irritable bowel syndrome, where we have abdominal pain. They include temporal mandibular disorders, so those are jaw pains chronically there. They include tension type headaches, so those are headaches where we have a band of pain across the head. And they also include pelvic pain syndromes, where we have pain along the pelvis, usually associated with dysmenorrhea and other period issues. One thing which ties all these conditions together is that they have minimal damage in comparison to the amount of pain experienced. The level of tissue damage that is evident seems to be completely disproportionate to the amount of pain which is being experienced. This is due to the central nervous system, that's spinal cord and brain, amplifying the pain signals. So we have a signal coming into the spinal cord, and for some reason that signal is then being boosted, giving us that disproportionately high level of pain. There may be some tissue damage and inflammation going on in the body, but when that signal from the body then goes to the spinal cord, it is then amplified. As a quick overview, the pain pathway begins in our tissues, muscles, tendons, ligaments, joints, the skin. It all begins there. We then have the local nerves in the area. They then bring the signal through the limb or torso, if they're in the torso, to the spinal cord. From the spinal cord, we then have a junction, and then the spinal cord takes it from whatever level in the spinal cord it came into and brings it all the way up to the brainstem. From the brainstem, it then gets projected across the brain. Once the signal reaches the brain, that is when we get the pain experience. One additional point to add is that within the brain, there is not a single pain center. When we tend to think of hearing or vision or taste, we tend to think about those being very specific areas within the brain. However, when we look at pain, there is no pain center. In fact, it goes throughout the brain in multiple different areas, and the accumulated signals of the brain then give us the total experience of pain. But there is not one single center. Instead, it's multiple areas firing off at the same time. Broadly, the areas in the brain involved in generating the pain experience can be separated into two, the medial and lateral pathways. The lateral pathway is involved in simply what sensation are we feeling. It looks at where is the sensation coming from? Is it from our hand, our knee, our foot? It then looks at what the character of that sensation is. Is it vibratory? Is it sharp? Is it dull? And then it also looks at the intensity. How intense is that pain signal? So it all looks at the sensation aspect. The medial pathway runs to the front of the brain, and within the front of the brain, it is really involved in how unpleasant is this sensation and how much does it make us suffer. We can almost see that same brain area at work when we have something very unpleasant. Think of nails on a chalkboard, polystyrene being rubbed together. That isn't painful, but if we look at our response to it, it makes us grimace, it feels horrible, but there's actually no sensation. That is those same brain areas at work. They're very uncomfortable and they make us suffer. And it is the combination of that brain area, the unpleasantness and the suffering, combined with the sensation area, which then give us the total pain experience. So we have the sensation and then the unpleasantness and suffering. In the pain amplification syndromes, the pain experience is amplified and exaggerated, and even sometimes can be wholly generated somewhere in that pain pathway. Now it may be from one area, perhaps it's only the spinal cord, perhaps it's only the brainstem or only the brain. Or it may be from multiple different regions. It's the brainstem, the spinal cord, and the brain. They might all be working together to amplify the pain. Furthermore, these conditions are vulnerable to flare-ups, what is a temporary increase in the pain experience. Again, we tend to associate a worsening in pain with a worsening of our condition, a worsening level of damage within our body. However, in these pain amplification syndromes, a flare-up, that temporary increase in pain, may be due to some changes within the central nervous system. It does not have to be because of an increased damage. Now, it's possible that that might be an input, but it's not the only possible cause. This is evident after flare-ups which occur after a psychological stress. Perhaps we exert ourselves cognitive, we do a lot of thinking, we do a lot of work. Or perhaps it's an emotional distressing situation. We experience a lot of emotional distress, or it may even be a lot of sensations, a lot of bright lights, a lot of loud noises, and that is an input into our psychology. That psychology can then cause the amplification of the pain and give us our flare-up, and is why sometimes flare-ups are associated with periods of stress. When we look at managing pain amplification syndromes, the first place we should start is actually in the local tissues. Is there anything we can do in the tissues which can help reduce any inputs into the pain pathway? Whilst the pain amplification syndromes are inherently, by their characteristics, caused by the central nervous system, there might still be some peripheral issues which are feeding into the pain pathway and allowing it to continue. Therefore, our first step is to identify any peripheral issues that we may be able to address. Once we have addressed those peripheral issues, we can then move to the central nervous system. Currently, we cannot assess exactly where in the pain pathway a particular amplification is occurring, or indeed at what percentage different areas are contributing. Therefore, currently when we look at the management of central nervous system amplified or generated pain, we have to look at it as a whole and treat it holistically. The medications which tend to be given in these central pain amplification and generating syndromes are those which actually work on the pain pathway centrally. They include antidepressants, so the serotonin, norepinephrine reuptake inhibitors such as duloxetine. They help by increasing norepinephrine within the spinal cord, which may help dampen pain. The next class are the anticonvulsants, the gabapentinoids, pregabalin and gabapentin itself. They actually block the nerves from signaling through to the spinal cord and may actually block the spinal cord itself from signaling. And so that actually blocks the pain signal. But that does come with a lot of side effects as well. One other medication which actually tends to be used more commonly is a low-dose naltrexone. Now, naltrexone at high doses is actually an opioid antagonist, meaning if someone is having an opioid overdose, they are given naltrexone and it actually blocks the effect of opioids. However, at the low doses, which is what is tend to be given in these syndromes, naltrexone almost has the opposite effect. It actually enhances the opioid receptors, allowing opioids, which are naturally present in our body, to work more efficiently and perhaps then will beneficially impact the pain levels. Those medications are often then coupled with a physical activity program, psychotherapy, and diet modifications. The physical activity program is often done in a start low and go slow method, meaning that we start with a very low intensity, nothing high impact, in order to prevent a worsening of pain. What we want to avoid is starting a high intensity activity program, causing an increase in pain and starting a pain cycle. So it's all about gradually building up our pace and going at a very slow pace. These physical activity programs also tend to include some physical rehabilitation exercises in order to help improve biomechanics, just in case there is a contribution to the pain by poor biomechanics and musculoskeletal issues. The psychology work is often an adapted form of an anxiety program. This is not necessarily because the individual themselves have an anxiety disorder. However, the brain areas involved in generating the discomfort and suffering overlap heavily with the same circuits which are associated with the development of anxiety. Therefore, if you have a program which works on anxiety, it will be working on the same brain areas involved in the unpleasantness and suffering of pain. Therefore, by performing an anxiety-targeted therapy program, we also target the areas involved in generating the pain experience. Finally, the diets deployed in the pain amplification syndromes are those which beneficially impact our overall metabolic health and gut bacteria, and those two have a knock-on beneficial effect of our overall inflammatory profile. The two most studied diets are the Mediterranean diet and the FODMAP diet. The Mediterranean diet is a diet high in fruit and vegetables, with a moderate intake of healthy fats and lean proteins, and a minimal amount of processed food or foods high in refined carbohydrates, such as simple sugars. The FODMAP diet, which stands for low fermentable oligo, poly, monosaccharides and polyols, is a diet which limits the amount of foods which may be poorly digested by the individual. If foods are poorly digested, they may sit in the digestive tract and be fermented, causing the release of gas, and that gas will then cause discomfort in the abdominal area. Therefore, by reducing those foods which are poorly digested, we stop that fermentation and therefore can help reduce abdominal symptoms. In summary, pain amplification syndromes are pain conditions where the level of pain is disproportionately higher compared to the evident amount of tissue damage. The pain level experienced is due to the amplification of the pain signal by the central nervous system. Due to the pain occurring from the central nervous system, the usual treatments which target the peripheral tissues and inflammation often are unsatisfactory. Therefore, the management should focus on targeting the whole pain pathway, tissues, nerves, spinal cord, brainstem, and the brain. Thank you for watching this video. If you liked it, then please do leave it a like. If you have any comments about this video or any other topics which may be interesting, then please do comment. And if you would like to see more of these videos, then please subscribe.